femoral locking compression plate, PFLCP. What is your take on that? For proximal femoral locking compression plate, PFLCP, particularly in those lateral cortex, blown out and things like that.
So personally, I am not a big fan of that plate. I've not used it I've used it only in rare and special occasions wherein I want to leave the intramedullary canal open for putting a graft, or when there's a non-union, when I want to achieve actual compression at the fracture site. I have no large experience. I've hardly used it maybe half a dozen times. If anybody else has got experience with
I have not used it.
I think I have used only a couple of times. But the thing here is the proximal femoral locking plate, you use it when your lateral trochanteric buttress is exposed, as has been already talked about. Even nail also can fail. And this is not, if the patient's age is not for an arthroplasty, you have to have some sort of internal fixation where you will have a stable fixation. So probably proximal femoral locking plate is one implant that is available for us. But if you see the literature, it's not favorable for this particular plate. Failures are very high. What I feel personally is, majority of the times, the patient's compliance is very important. Our patients are not that compliant. Not only our patients, anywhere. Human being is anywhere the same. Once you fixate, patient thinks that everything is all right. Probably patients are not compliant and they might start putting weight prematurely. They can't have the patients to wait until because this plate is not that strong to hold the fragments. Femur is such a bone. Plating is always not an ideal implant to use. We know that for femoral fractures, nail is the implant of choice. But in situations like this, when you use, you make sure that the patient is compliant, educate the patient, counsel the patient, and if the patient is going to follow your instructions, probably it should work. That is my impression.
There is no question. The commonest complication with hemiarthroplasty and trochanteric fracture.
Commonest complication in so far in my experience, as I said, I have done more than 100 cases. Nowadays, it has come down because of the PFN. Earlier, I have done quite a good number of them. As far as my follow-up is concerned, one is trochanter non-union is one of the complications. And second thing is heterotopic ossification in some cases. You are talking about IC fracture, IT. For IC or IT? IT, that's what I'm saying, IT fracture only. So I can't say common complications. These are the ones which I have noticed in my practice. IT fracture, hemiarthroplasty, trochanter non-union is one. As I said, I put tension band wiring. Sometimes it snaps and the trochanter can go for a non-union. I have seen in some of my cases that is happening, but still patients manage a little bit of pain in that area and some tendon backlash. If you ask them to use a walking stick or a crutch, they will manage well. And in some cases, I have seen heterotopic ossification also. Infection, like in any other case, I don't think there is any great risk of infection. And perioperative complications, as I said, I have not come across myself like, these embolic manifestations because of the way I do it. Second thing is, perioperatively, the blood loss and other things, of course, that is not an issue at all. Dislocation also. If you follow what I have said, I think dislocation also is kept at bay. That's not a problem for me, at least. I can honestly say. I didn't have much of in my whole of my experience, I think I have seen a couple of dislocations. Entire hemiarthroplasty you take for IC, EC, everything. Only 2 times I had dislocations. That too, one patient gave the history of fall, the other one was a neurological patient. So if you follow the technique meticulously, I think that complication rate can be kept on. It's not, doesn't mean that I don't have complications, definitely will be there, but the question you put me, commonest, means these are the things which will come to my mind.
Dr. Walia, can I ask one question? Sunil, you were supposed to talk to us about non-unions, if there were any, in the young. So what would be your strategy? Because you showed only arthroplasty options as revision. What would be your preferred choice to, say, salvage failed fixation without cutouts, as you showed one DHS where the screws were coming off, in a younger patient where you want to preserve the head? What would be your strategy?
I showed you 2 cases, Srikanth, you were sleeping.
No, that's because you are so obsessively showing us all the arthroplasties that I missed that little.
Yeah, that just
Fleeting
shows the
2 slides.
incidence. That just shows the incidence of failure of intertrochanteric fracture treatment in younger patients. Yeah, so
but
that's a very small
No.
percentage of patients we are talking about.
No, my question is, if supposing you're faced in a young patient, what would you do? What would be the best
To
choice?
preserve the hip.
Yeah, how? If, say, a DHS has failed, how would you preserve the head? Would you do a fixed plate, sort of angle plate, like a blade plate or a DCS?
It depends on where your defect is. It depends on where is your bone stock to get purchased in the head. That is the most important thing, because on the shaft you're not worried. You're worried only about the head to get the proper fixation in the head. It depends on which quadrant of the head that you're able to get purchased. Whether you can do a DHS or you need to go to an angle blade plate or a DCS. If you have inferior bone stock in the head, then all you can think about is going for a 95-degree plate or a DCS. But at the same time, if there is bone adequate enough where you can fit in any of the other devices, then you would go in for them. The problem with the DCS and angle blade plate, all these things are, at least for our generation, we are not used to doing these things. And what happens is you've got a complicated case where you've got so many other problems, and all of a sudden you're using a device which you're not all that familiar with. So I would say it depends on where the defect is. If you can do a DHS again or a PFN again, provided you can put your screws in a place where you can get a good hold, then you would try to salvage the head.
What do you think? I mean, I'm trying to get to, I've been given a brief to prolong this discussion, so I'm trying to ask you questions. Anyway, the reverse Z effect, why does that happen? You know, failure of PFN could be either the Z or the reverse. So the Z, I can understand the collapse of the fracture, so it's moving forward. What happens for the, I mean, I've shown some x-rays myself of published pictures why the top screw falls out.
You're a better place to explain that, Srikanth.
No, I'm asking you because you were talking about how to salvage. So you must have seen something else as to some of the paper which has referred to this failure mechanism in the PFN.
Not that I've come across.
I think Dr. KJ is here, so my job is done.
Mehmet on behalf of NOSA, sir. Thank you very much, sir.